My name is Evan Lederman from Phoenix, Arizona, and I'm going to talk to you about expanding treatment options for the atypical glenoid. Of course, our goals for reconstruction and anatomic shoulder replacement is to restore version, inclination, restore the anatomic joint line, rotator cuff tension, preserve bone, get stable fixation with good backside contact support, and get a durable result that's hopefully revisable as well. For the reverse shoulder replacement, we also want to restore version. We need to restore inclination towards a neutral inferior tilt. We may want to get an anatomic joint line if we ever figure out where that's supposed to be. Restore rotator cuff tension, of course, get fixation, durability, and revisability as well. The Walsh classification has been the accepted classification for glenoid deformities, and it was modified in 2016 with the addition of the B3 glenoid, which has loss of the normal paleo glenoid and significant retroversion, and further clarification of the A2 glenoids with significant medialization. So if the glenoid's so challenging, why don't we just put a reverse in everybody? And the reverse we're using nowadays is not the same reverse we had in the early days. But as we look at the outcome of the reverses we've had available, we get better functional outcomes with anatomic shoulder replacement than reverse shoulder replacement, with better external rotation, forward elevation, higher postoperative strength, and higher rates of return to sporting activities in our anatomic shoulder replacement patients. And the SOS data has also shown better ASCS and SANE scores with the anatomic versus reverse shoulder replacements in the older patients over 65. So why do our anatomic shoulder replacements fail? They basically fail mostly on the glenoid side or on the rotator cuff side. And if we fail to correct version and inclination, we're going to get edge loading either posteriorly or superiorly, leading to early loosening. If we excessively ream, we'll get loosening and migration of the component. And if we get incomplete backside support, we'll get micromotion, leading to radiolucent lines loosening and sometimes breakage. The VIP, as you've seen, has helped us a great deal, and as we do our surgical planning, we can see that we can't correct the anatomy very well sometimes without having to deal with these glenoid bone deformities. And when we do have deformities, our options are corrective reaming, bone grafting, an augmented implant, the convertible glenoid that we'll hear a lot more about, and reverse shoulder arthroplasty. And as we get these more significant bone loss deformities, our options narrow, and our goal, of course, is to restore the joint line, save bone, and support the implant. But these aren't two-dimensional deformities, they're three-dimensional deformities. And from work out of UConn from Gus Mazoka, we've identified that they can be posterior superior, directly posterior, or posterior inferior, and the implants need to be able to accommodate these different options. Eccentric reaming is what we've done historically, either leaving the retroversion where it lays or medializing, except the problem is as we ream the glenoid, we lose backside support. And Gilles Walsh and his group has showed us that the excessive reaming will lead to glenoid loosening over time. But interestingly, you don't really see it in the first 5 years. You've got to look beyond 5 years to see the consequences of our actions. And we need to preserve as much of the subchondral bone as possible. The Universe Vault-Lock glenoid was designed with this intent to have variable backside radius of curvature so that we remove less bone, and having a central flute will hopefully enhance fixation, leading to less micromotion. The technique is simple and works with the VIP system for guide pin placement. We want to make sure we get backside support for the implant, and it's an inline peg design that's been a durable design through the years. We want to bone graft our central peg, and the technique of bone grafting utilizing the humeral head is shown on the right, and then the minimal amount of cement in the peripheral pegs. We've done a prospective randomized study looking at 153 patients with 51 in each group using humeral head autograft versus DBM versus no graft. And in the study, we identified that with humeral head autograft, we got 90% bone ingrowth in the central peg, with no graft, 62%, and with DBM, 70%. With increased bone growth into the flutes, there's less glenoid loosening to be shown over time. So our recommendation with this implant now, and this has not been published yet but recently presented, is that you use humeral head autograft for this procedure. Bone grafting techniques to support the backside of the glenoid have been described going back to the 70s and universally use the humeral head as the graft source. And of course, the idea is to build up the back to support the anatomically positioned glenoid. The best technique has really been described by Joe Iannotti, using the anterior portion of the humeral head, which nicely matches the posterior contour of the retroverted glenoid, and fixing it with screws, and then preparing the lateral border of the bone graft to match the backside, and then placing the implant with good backside support. However, when we look at the bone graft studies, the published studies out there, the early ones by Steinman looking at Cofield's experience and Hill looking at Norris' experience using first-generation implants, had a fairly high failure rate. As we've moved towards the more modern implants and a combined study of second and third generation implants from Mayo Clinic as well, they had improved results going out to midterm follow-up. And Greg Nicholson, looking at a group of strictly third generation implants, showed very few revisions in midterm follow-up with bone graft support. Bone graft has been a mainstay in my practice since the beginning of my practice. This is an 8-year follow-up with no glenoid loosening, no screw breakage, and this has worked well before some of the more available options we have now. And the key components are to get fixation of the glenoid in the native scapula, correct the retroversion. You need meticulous bone prep so it grows together. You got to recess the heads of your screws so it doesn't pedestal your implant. You got to get stable backside support, and if you don't, you need to divert to something else and avoid cement in the fractured area. Because of the challenges with the bone grafts, the augmented glenoids have been developed on the market. The goal here is, of course, to restore the anatomic joint line and retension the rotator cuff. And there's basically 3 general designs: a half wedge, a step, and a full wedge. And the potential here is to fill the defect utilizing plastic instead of bone. Despite them being on the market about 9 years or so, there's limited studies all in short-term follow-up. And as we know from Jules Walsh, we won't see problems with glenoids for at least 5 years. But in short term, these have shown to be a good solution for dealing with these bone defects. And we will, as Kevin Gallen showed you, we will have these implants available for review utilizing the wedge, half and full wedge designs. In Europe, the metal bag glenoid has been used as developed by Peter Habermeyer since 2011. It's convertible, which is very desirable as rotator cuff failure is common. However, the implant's thick. The combined implant between the metal and the poly is 7 to 8 millimeters in thickness. But if you look at historical metal bag glenoid experiences, even though they have some degree of a bad reputation for glenoid loosening, when they do succeed, the bone is well preserved, and in this case, 17 years post-op, there is absolutely no bone erosion or bone loss in this implant, which can make for fairly simple revision. Dr. Habermeyer's indication in his population has been older patients who are still very active, but a medialized glenoid with a variety of glenoid pathology to allow room to place the thicker glenoid implant and still maintain the anatomic joint line. And he recently reviewed 66 of his patients with an average 43-month follow-up. 40% of these had posterior subluxation. He used a variety of glenoid conditions across the board. Of course, the constant scores were improved, as you would expect. And on the glenoid side, in rigorous radiographic analysis, they have found minimal radiolucent lines and minimal glenoid risk. They did have 2 polyethylene dissociations in their very early experience and no loosening of the construct. He's done a secondary follow-up study at a minimum 4-year follow-up and out to 7 years, looking at sequential x-rays, and they're showing that there's no progressive radiolucent lines developing in these 2 studies so far. The complications in this series included 1 infection, 1 prosthetic instability requiring revision to a reverse, and 4 rotator cuff failures requiring revision to a reverse. And in all those cases, they could simply just pop the poly and put a glenosphere on. They did have the 2 poly dissociations and no glenoid loosening. As we looked at the more deformed glenoid, Pat Denard and Jules Walsh has shown us that at a certain level of deformity, we really can't do an anatomic replacement very well. And the numbers are approximately 80% of posterior subluxation or greater than 20 degrees of retroversion of the neoglenoid. And the indications for a reverse shoulder arthroplasty and primary arthritis have to do primarily with glenoid deficiency, greater than 80% humeral head subluxation, the inability to correct deformity back to normal anatomy. Maybe it's 10 degrees, we're not sure about that. You want to be able to get adequate glenoid component seating in the anatomic, or else you're going to have failure. And if there's excessive retroversion, vault compromise, or medialization, we need to consider reverse. In this representative case of a 50-year-old male, fairly active with significant posterior superior glenoid deformity. You can see he has a 30-degree deformity with posterior superior glenoid bone loss. We couldn't get an adequate plan for an anatomic shoulder replacement. We elected to use reverse shoulder replacement to correct both the superior inclination and the retroversion. And in this case, we used a humeral head bone graft to fill in the defect. But with this particular implant, we pretty much reached the maximum amount of bone we can correct because much of the native implant was placed into the bone. With the advent of the MGS, we can pretty much get away with just about any size of bone graft we need to do now. As Kevin told you, we have modularity in the system. We have 2 sizes, 24 and 28 millimeters. 24 is the smallest base plate on the market. And we have the ability to lateralize with metal a little bit further. You can have a modular implant, modular screw or post between 15 and 35 millimeters, and we've added the 33 glenosphere as well, and we still have the 0+4 and 2.5 millimeter inferior option as well. It's been coated with BioSync. BioSync has been used on other products out there. BioSync has an extremely favorable bone ingrowth compared to other materials that we use for similar applications. But the greatest thing that I like about this in my practice is the ability to metallically lateralize. And using different combinations and different combinations of glenosphere, we can now lateralize 0, 2, 4, 6, or 8 millimeters with the metal. And we've already shown in a previous published FDA study that we can lateralize up to 10 millimeters safely and not have excessive force on the glenoid. This technique is very simple. You can use a VIP guide or a standard round guide. We place our guide pin. 2 one-step reamers. You never have to go back and ream again. You ream to a flat surface to the base plate, and then we ream the peripheral amount of bone so it doesn't affect the glenosphere. You have a central drill. I prefer a post over a screw, but you can use either one that you want. If you use a screw, you got to tap as one extra step. We assemble the implant to a recommended compression with that device. We then just hammer it in. We have variable angle compression screws or fixed angle locking screws that are 10 degrees divergent, and there's 4 holes. You can do 2, 3, or 4 screws, whatever you like. Overall, it takes about half the time to implant this glenoid from the other glenoid. This is a revision of an anatomic total shoulder replacement that was done for B2 glenoid. I did this case, and I didn't get full backside support of the glenoid. It looked good for many years, but at 7 years, it started to show radiolucent lines, and at 8 years, the glenoid broke, and we had a central and posterior uncontained defect. We were able to do this revision with the MGS system utilizing the +4 base plate with the +4 glenosphere and be able to accomplish this operation without having to use structural glenoid bone graft, which was very satisfying. In this next case, we have another significant deformity, 30 degrees of version abnormality, superior inclination, and was unable to plan this with an anatomic shoulder replacement. This is a bone graft with the MGS plate system. We're able to restore the lateral aspect of the joint very effectively to get a good result. So in summary, for minimal deformity with an A1, A2, or B1s and B2s less than 15 degrees, you can do some mild eccentric reaming and place an anatomic replacement where it lays. For a B1 and B2 between 15 and roughly 28 millimeters of retroversion, a bone graft, an augment, or a convertible glenoid if you have a medialized, if you can put it in a medialized position. And for the greater degrees of deformity, we have the ability to put a reverse now with more metallic lateralization on the glenoid side, or you have the option of a bone graft with a nice long central post to get the native implant in the native scapula. Thank you.